Coarctation of the aorta, COA. 5 to 7% of CHD. Constriction of the aorta of varying degree which may occur at any point from the transverse arch to the iliac bifurcation. F2, 1. May be a feature of Turner syndrome. Associated with bicuspid aortic valve in greater than 70% of cases. Types and pathophysiology. Discrete juxtaductal obstruction, adult type. 98% of cases. Occurs just below the origin of L subclavian artery, at the origin of ductus arteriosus. LV hypertrophy and LV height. LR ductal shunting occurs following birth. Productal, infantile type. Tubular hypoplasia of transverse aorta, starting at one of the head and neck vessels and extending to ductal area. RVPDA descending aorta, RL shunt. Palpable femoral pulse, differential cyanosis. Sever pull. Height and high pull. Vascular resistance and HF. BP elevated in vessels proximal to coarctation. BP and pulse pressure lowered below coarctation. With time collateral circulation, early adulthood. Clinical manifestations. After infancy, most patients are asymptomatic. Some children, adolescents weakness or pain, or both, in lower extremities after exercise. Height on routine physical examination. Classic signs. Disparity in pulsation and BP in the arms and legs. Weak or absent pulse up to 40%, in LL, bounding in ul and neck, lower BP in LL relative to ul. Radial, femoral delay. 90% of patients have systolic height in ul greater than 95th percentile for age. Precordial impulse and heart sounds are normal. Systolic thrill in suprasternal notch bicuspid as. Short systolic murmur along L sternal border at 3rd, 4th ICS well transmitted to L infrascapular area, neck. Murmur of as 3rd RICS. In older patients systolic or continuous murmur heard L and R sides of chest laterally and posteriorly associated with a palpable thrill. In neonates or infants with severe COA. Sign of lower body hypoperfusion, differential cyanosis. Acidosis and severe HF. OE cardiomegaly. Systolic murmur, heard along L sternal border. Loud S2. Investigations, CXR, finding depends on age, effect of height, collateral circulation S. Infants with severe COA cardiomegaly pull, congestion. After first decade. Mild, moderate cardiomegaly, LV. Notching of inferior border of ribs, late childhood. Descending aorta has an area of post-stenotic dilatation. ECG, neonates and young infants are orbiventricular hypertrophy. Young children normal. Older patients LV hypertrophy, cardiac catheterization and selective L ventriculography and aortography. Echo. Visualize the segment of coarctation, and look for associated lesion. Cardiac catheterization and selective L ventriculography and aortography. Visualization of collateral blood vessels. Treatment. PGE2 infusion for neonates with severe COA and management of associating HF. Surgical repair soon after the diagnosis and stabilization of the general condition. Timing of surgery should not be delayed after second decade because of associating LV dysfunction. Prognosis and complications. CVA severe neurologic damage or death. Premature coronary artery disease, HF, hypertensive encephalopathy, intracranial HG complication of height. Infective endocarditis or endarteritis adult. Aneurysms of the descending aorta and of collaterals. HF and hypoperfusion, life-threatening. Complication of associating lesions. Abnormalities involving L subclavian artery, tetralogy of Fallot, TOF. 5 to 7% of CHD consist of obstruction of RV outflow, RV infundibulum, PS. VSD. Dextroposition of the aorta with septal override. RV hypertrophy, pathophysiology. Clinical manifestations. In infancy, mild RV outflow obstruction HF, LR shunt across VSD, with no cyanosis at birth. Cyanosis occurs later in first year of life. Severe degree of RV outflow obstruction neonatal cyanosis, severe collapse following closure of ductus arteriosus, older children. Cyanosis with dusky blue skin, gray sclerae and engorged blood vessels. Clubbing of fingers and toes. Dyspnea on exertion and tendency to squat. Paroxysmal hypercyanotic attack, hypoxic, blue or tet spells. Common in first 2 years. Hypopnea, restless, cyanosis increase, gasping respiration and syncope may result. Occurs in the morning after initial awakening or after a vigorous crying. Lasts from few minutes to few hours, rarely fatal. Disappearance or decrease in the intensity of murmur. Mild attacks weakness and sleep. Severe attacks unconsciousness, convulsion, hemiparesis. Prolonged attacks severe systemic hypoxia and metabolic acidosis. Growth and developmental delay. Physical signs, precordial bulge with substernal impulse RVH. Systolic thrill along L sternal border in 3rd and 4th th parasternal space. Systolic murmur, ejection in type at the upper sternal border, holosystolic at the lower sternal border. S2 either single or pulmonic component is soft. Continuous murmur in presence of collaterals. Investigations CXR, ECG, normal in size, boot-shaped. Clear hilar and pulmonary vascularity, oligemic lung. R-sided aortic arch in 20 to 25% of cases. ECG. RVH, P pulmonal, RAD. Echo. Cardiac catheterizations. Treatment. AIM provides an immediate increase in blood flow to prevent the sequel of severe hypoxia. Lines of therapy. Maintenance of normal body temperature and blood glucose. For administration of PGE potent relaxant of ductal smooth muscle. Prevention and prompt treatment of dehydration. Iron therapy improves exercise tolerance and decrease the frequency of spells. Oral propranolol decrease severity and frequency of hypercyanotic spells. Surgical treatment as soon as spells begins. Palliative systemic to pulmonary artery shunt. Blalock, Tausig shunt. Corrective open heart surgery. Treatment of hypercyanotic spells. Placement of the infant on the abdomen in the knee, chest position. O2, rehydration, morphine, not greater than 0.2 mg/kg SC. Correction of metabolic acidosis NACO3. Drugs increasing systemic vascular resistance, phenylephrine, methoxamines, B blockers.